physician currently employed at the University of KwaZulu-Natal Department of Family Medicine as a lecturer specialist. He is also a fellow in the College of Family Physicians under the Colleges of Medicine South Africa. He has a master's degree in family medicine, and his master's research focused on the internship training program in KwaZulu-Natal to see if adequately prepared South African medical graduates for community service. He has a special interest in rural medicine, thus worked in a rural district hospital for 4 years as a family physician prior to joining the university. On joining the university, he was appointed as the academic coordinator of the undergraduate final year medicine rural block placement, which places final year medical students for 6 weeks in rural district hospitals. His interests in rural medicine further extend into experiential learning in rural district hospitals. Thus, he is involved in a few projects that look to improve medical education and collaboration in such environments. From 2019, he has been involved in a project funded through an international grant to UKZN that looks to strengthen interprofessional education and was appointed as a key personnel in the project from 2020. He was also appointed a South African ambassador under AFRI Health for this program. Currently, he is busy with his PhD, which is located in medical education and looking at medical doctors' understanding of their learning in a rural environment. Over and above this, he is a firm believer and advocate for social justice, thus is chairperson of a local NPO called Kwa Care, which supports and educates over 60 children in a local community in Durban. He is also a trustee in Umthombo Youth Development, an NPO that funds underprivileged students to go to university to study for health sciences degree. So thank you so much for being here this morning.
Absolute pleasure. Thank you for having me. All right, so are you happy I go on with our presentation?
Yes, please begin whenever you're ready.
Okay, perfect. Before I even start sharing my screen, just want to say hi to Tracy as well. Good to see you, Tracy.
Sorry, I was a couple minutes late. It's my son's 6th birthday, so we were picking out birthday donuts.
Oh, well, happy birthday to him. Yeah. Great, thank you. All right, I'm going to share my screen and yeah, I'll get started. Great, so just to confirm that everyone can see my screen.
Yep.
Okay.
Yep.
Perfect, thank you very much. All right, so yeah, welcome everyone, and thank you for rising early on your side to listen to some stories from South Africa, and especially around mental health. I certainly hope that I will get to meet some of you one day, either when you are visiting South Africa or obviously when I'm visiting the States, hopefully in the near future. So yeah, so we're going to be speaking about mental health, and you know, the way I've basically structured this talk is on trying to focus on really, I think, the fundamental issues around mental health in South Africa, but also some of our structures in terms of how the structures function so that you can locate mental health in South Africa in a certain picture. And hopefully, I hope that you'll be able to even compare how you experience mental health in the States, and you know how we experience mental health in a third world type of country scenario. So I'll be giving an introduction. I'll go over a South African perspective and just give you a bit of history around that. Then speak about integration of mental health into primary healthcare, which is basically the model of care that majority of our country focuses on. And then, you know, we'll go into a bit about our health systems, just so you have a little bit of understanding on our health systems and how they function. So again, you can locate some issues around mental health care within our system. I'll speak about psychiatrists in South Africa, just in terms of their training, how many we have and so on. and then obviously practicing what it means to practice primary mental health care within a South African setting, and then going to community involvement and certainly the complexities of social-cultural factors around mental health within the South African setting. I must apologize right from the beginning. My slides are quite busy, which is not the way to do PowerPoint presentations. But, you know, there's just so much that I think can one speak about, but also just in terms of information, which I thought was critical. So it's great that, you know, these presentations are recorded. So you can actually always even go back and actually just get a bit more in terms of what's on those slides. So first and foremost, I'd like to start with a case. And this case basically is a case of an individual, hypothetical individual, who goes to look for mental health care within a rural South African platform. And again, just to try help us to get a picture of what would happen to a patient who comes to a rural South African hospital or lives within a rural South African context and is seeking mental health care. So Mr. Mhlabuya Lingana is a 33-year-old male who's brought in by the police to the district hospital casualty after he was found breaking windows in the community. He was also reportedly verbally aggressive towards community members in a particular area and was walking around naked. Unfortunately, there are no family members for further collateral history as he lives alone in a one-room shack and is identified by one of the casualty nurses who's actually from the community as well. He last had official contact with his family 3 years ago. He's also known, also well known to the hospital with multiple previous admissions for 72-hour observation, which is an observatory period that we have under our Mental Health Care Act, and referral thereafter to a psychiatric institution. He is once again admitted into the medical ward in order to rule out a general medical condition and for observations for 72 hours as per the Mental Health Care Act regulations of South Africa. And on completion of his 72-hour observation, he is transferred to a psychiatric hospital, which is 3 hours away from the district hospital. And he spends 2 months there as an inpatient. 2 months later, he returns to your district hospital with medication to be taken as an outpatient and is discharged by yourselves for him to go home with the review date set for a month's time. Okay. I think to start off, and I think in keeping with that story that we've just basically gone through, it's important that I raise an issue that gives us a picture of the struggles of mental health practitioners, but also mental health care patients within a South African context. And some of you might have heard of what we call the Life Esidimeni tragedy, which happened in 2015 in South Africa, in one of the provinces, which is our main hub, economic hub, which is Johannesburg, Gauteng, basically. And what happened here was that the Department of Health of that particular province decided to terminate a 40-year-old contract with Life Esidimeni, which was an organization basically that was providing mental health care to over 1,400 individuals. And this was mental health care that was for medium to long-term care, basically, within this institution or facility. And so for a lot of individuals whom their families could not take care of them, they would admit them into this institution and they would get all the care, you know, through visiting psychiatrists, through nursing care, through getting food, through all the you know, psychosocial support, cognitive behavioral therapy, you name it, within this facility. But basically, because the Gauteng Department of Health Management felt that for them, they needed to terminate these services purely on, according to them, affordability basis and the need for reprioritization of funds for them to be able to do other things with the funds that were being paid to this facility to care for these individuals who are admitted there. So patients were moved over a period of about 8 to 10 months, basically, to other institutions. So it was to 2 specialized psychiatric institutions, to rehab centers, and then to 27 non-governmental or non-government organizations that were spread around Gauteng, which is this province again in South Africa. Now, how this move was done was highly rapid. It wasn't really in keeping with how we would transfer many of our psychiatric patients from one institution to the other. Neither was it done with watching for how the Mental Health Care Act, should be rolled out, basically, when you are referring a patient from one institution to the other. So many patients were lost to follow up during that 8 to 10 month period, where basically the families didn't know, firstly, that they were being moved, and secondly, didn't know where they were. So they all of a sudden would look for their family members at this Esidimeni Life facility and wouldn't find them. And unfortunately, during that time, 144 people died due to lack of proper care, starvation, lack of proper mental care, mental health care being provided to them. Some of the facilities weren't really zoned appropriately to care for mental health individuals. And this led to a massive inquiry that happened in Gauteng. The Minister of Health of South Africa also got involved in this to try and inquire exactly what happened. The legal services obviously got involved because there was a legal charge against the Gauteng Department of Health, amongst other things. And much has been written about the unfortunate event that we saw. And as you can see from that picture at the bottom, blame that actually happened even amongst individuals who were managing the Department of Health for Gauteng at that time. And really why I'm raising this is because what we saw in the economic hub of South Africa, being Gauteng, being Joburg, and so on, is just a glimpse and a small picture of things that are happening within the rural mental health care spaces, in terms of lack of resources, in terms of lack of care, even though individuals try, but because of other things that come into play and affect how mental health care is actually meant to be provided within a South African rural context. So I think just coming back now and us looking at a global picture. So, globally, we know already that very little attention is given to mental health. Certainly in the high income countries, they spend about 5% of their health budgets on mental health, whilst for us living in low middle income countries, we spend 1% of on average on mental health. And to further zone in into an African setting, 70% of African countries spend less than 1% on mental health, within Africa. And so untreated mental health really accounts for, over 13% of total global burdens of disease. And this number is rising exponentially. We're waiting for the next World Health Organization review and, publication around mental health care issues, and especially obviously post what has happened in the last two years as well, or 2.5 years with the pandemic. And so psychotic disorders, both in developed and developing countries, really represent majority of the burden of care and important causes of disability and losses to the economies. And again, that has been made even worse in the last 2 years. Neuropsychiatric conditions, we know, affect about 10% of global populations, with serious mental health issues affecting about 3%. And for a South African perspective, 1.4 million of our people suffer with mental health in South Africa. And that number, again, is just documented individuals. It's probably much higher than that. It's probably double of that. It is estimated that by 2030, depression will be the leading cause of disease burden worldwide. And I think that number, again, because of the last 2.5 years, is probably coming down. And we might be finding that we're getting even closer to that being the leading cause of disease burden within South African or in in a worldwide sort of population. So it does not help also that besides challenges of funding and lack of policy implementation, mental health and psych remains a stigmatized field, even amongst medical professionals. You know, we certainly, again, have seen that in the last 2 years, where mental health care issues are things that even medical professionals or personnel are not wanting to deal with, are not wanting to be open about. And it's worse within a rural South African setting. So there's this unspoken burden of mental health on societies. And, you know, within the primary healthcare setting, a quarter to a third of disorders are psychiatric in nature. Much of what we see, even within a district level hospital, is psychiatric in nature in terms of presentations. A high proportion of these illnesses are not even diagnosed, or they mismanaged as something else. And this obviously leads to quite a bit of distress and ongoing disability for those particular communities. And we know that, again, the World Health Organization reiterated in 2008 the need for integrating mental health into the primary healthcare sphere because, again, majority of patients are seen within the primary healthcare setting. And obviously the functionings of the primary healthcare setting are very much on that biopsychosocial systems approach, certainly within a South African and South African rural population. Thus, this will hopefully ensure that there's somewhat holistic patient care that is provided for individuals. So what about in a South African perspective? South Africa has a great history in terms of apartheid. And post this apartheid democratic South Africa, we unfortunately inherited a very fragmented and under-resourced public sector, specifically for mental health care services. 52% of our total population and 75% of the poor live in our rural communities. So you can imagine 52% of our population live within rural spaces. And 75% of those individuals who are poor and live in those spaces are within rural communities. So a lot of these individuals are very reliant on treatment from, obviously, our healthcare system, but also treatment in large centralized institutions for mental health, because we need these centralized institutions for them to get this ongoing care. It's very difficult to do it within a district level hospital where you're trying to deal with a whole lot of other primary healthcare problems that are happening there. Yes, there's been great strides in terms of mental health services, being provided and trying to be equitable in keeping with the health policies that have been put out there. And certainly there's recognition that mental health is very important as a health issue in a South African setting, even though we still have issues like the Life Esidimeni tragedy, which happened in 2015. And so we always constantly even thinking about that. And I think if we zone in even more in terms of rural health and mental health within our rural spaces, proper mental health care is really still lacking, within a rural South African setting. And in fact, for many people, they've even labeled it as dehumanizing in terms of how we've handled it. And this was a campaign report that was published in 2015, again, even around the time of what was happening in Life Esidimeni. So there's a whole lot of disproportionate distribution of the mental health human resources in terms of when we look at our urban spaces and when we look at our rural spaces within a South African setting. I mean, I speak about, living within a Durban setting. If I have a patient who needs mental health and they can afford privately, they can go to a beautiful institution in, the Berg, basically, which is a nice environment where then they can get the services that they need, where they've got the full-on support of the psychologist, the psychiatrist, they've got occupational therapists, you name it. We don't have that for our patients who are within the public healthcare sector and the rural sector in particular. It's very, very limited. And so we can't just admit patients for that holistic care, and so often we find ourselves shoving pills at patients to try to deal with the issues we have. Also, the density of our psychiatrists in or around the largest cities is about 3.6 times greater than the density of psychiatrists in the entire country. So you can imagine, there's very little psychiatrists being, again, in the rural spaces and supporting the rural spaces because of multiple reasons, of course. And so the distribution of even the mental health nurses between urban and rural is actually not known, in terms of the actual numbers. But we know that it's certainly lacking within the rural settings as well. So really the rural areas then often rely on generalist doctors, occupational therapists who are junior because they're ComServes and they have to do what we call community service in the South African setting, and nurses then who have some limited training in mental health interventions. It relies on those individuals to be the ones to provide the mental health services to those particular communities and individuals within those communities, again, with very limited resources available to them. Now, there's certain studies that have been done to even look further into the mental health issues in the South African setting, but I think to highlight certainly two of them, which are doctoral studies that were done by Brathen and Brooks Sumner, who actually investigated the state of rural mental health in South Africa. And they revealed in part that there needs to be a shift of care between or from pacifying to actually activating. That's actually broader than just the healthcare system. Basically, what they were saying here is that we need to focus more on task sharing models of care amongst individuals who are found within that community and not just limited to, us as the healthcare providers from a Western perspective, providing mental health services to the communities. So care of people basically with mental illness is not just about the cure and treatment, but it's also about prevention and promotion of mental health care. And so they're saying we need to be focusing more on that and not wait for individuals to come and receive a pill, basically. So they're emphasizing the importance of community-based models of approach, where even the traditional health providers and religious societies and non-governmental organizations, one, are trained to be able to provide these services adequately, and then are involved in providing these services accordingly. So interventions need to be locally relevant, basically, and culturally consonant, as culture shapes illness experiences for many rural communities. If I give examples of patients that we would see within a district rural environment, these patients come to us, and a patient might have schizophrenia, for instance, and they come through hallucinating, having delusions, grandiose delusions, religious delusions, and you name it. But for the family and for the community from where they come from, their culture might be actually seeing that as a calling. And this individual is being called by their ancestors to be able to start to provide health and healing in communication with their ancestors. But from a medicine and Western side of view, we see this as an illness. And so, there needs to start to be a link in terms of understanding the cultural aspects and where these individuals come from, and then see how can we start to link this with what we're providing from a Western side, so that we're not, overruling things that might be seen as appropriate within that particular community. So South Africa, in terms of integration now into primary healthcare, South Africa has integrated mental health into primary healthcare on paper through legislation. Policies and legislation advocate certainly for community-based models of healthcare service provision, okay? A comprehensive and community-based mental health service, which is planned and coordinated at national, provincial, district, and community level, and integrated with other healthcare services, is something that Department of Health says they are doing. But unfortunately, the implementation hasn't been even across the provinces. There's lack of allocation of beds. We don't know in terms of population numbers for the amount of services that we need to do in certain rural communities. Lack of resources, there's poor staffing and there's poor training. And this is an ongoing process. So we might see that, yes, with those three bulletins above, where legislation and the acts are saying and the policies are saying, we are doing this on paper. But physically, when we are seeing patients within a rural community, we're noticing that there is massive gaps and things that still need to be filled in, basically. and provisions of care would still need to be heightened for those particular environments. The other unfortunate part is that because we've got 9 provinces in South Africa, the budgets and the health budgets are controlled by the provinces. And so National Department of Health and the Minister of Health doesn't really have much of a say in what the individual provinces do in terms of their national budgets. Hence, again, the Life Esidimeni tragedy, which happened, where all of a sudden the province can decide, no, we're pulling away funding from mental health, even though nationally it is gazetted. There's a policy that says we should be providing mental health at a certain sphere. So all of that, again, comes to affect the way we provide mental health services in the South African setting. Now, I've spoken a lot about, obviously, the rural environment, the provinces, healthcare in terms of urban and rural. But really, if we think about the healthcare services in the South African setting, there are 2 main components. There's the public health system and there's a private system. And in terms of numbers, we unfortunately have 70% of our doctors in the country servicing about 30% of our population, which is in the private space. And then 30% of our doctors in South Africa servicing 70% of our population, which is in the public space, which is where free healthcare is being provided for individuals. There are other components that we need to be thinking about, which is traditional healers, alternative medicine, non-governmental organizations, community-based organizations, and faith-based organizations, which also come into play and form part of the South African healthcare system, even though these alternate or other components are not as recognized by those 2 main systems, the public and the private sector. So they're not really working hand in hand. Yes, again, there's been some effort, certainly within the rural space, for individuals to start to work with the traditional healers, the alternate medicine, and the non-governmental organizations, but it's not going as it really should. And if we look at the ecologies of medicine and medical care within a South African space setting, majority of individuals are seen at a primary healthcare level, and very, very minimal individuals right at the bottom corner and you're right there are seen within the academic spaces where we've got the super specialists and specialists, and within the hospital settings where, we've got the psychiatrists and so on. But what is happening in our community levels? And obviously we need the levels of care because we need to be able to control who is receiving care and how they're receiving care, and that care is equitable. But we are struggling, I think, as a nation. So certainly, again, just to emphasize this inequality or inequity, and especially if we look at it in the sense of, thinking around economy and money and how money is being used. So 4.1% of our spend as a South African nation is literally for 16% of our population, which is covered by the private sector. And 4.2% of our spend is for 84% of the population covered by the public sector. So again, you can see how it's very easy for individuals in the private sector to get healthcare, but much harder for greater population who needs healthcare to be getting it within, that public space. And again, about 12% of our doctors and 19% of our nurses work within rural areas. And obviously our hospitals are within communities, but there's also this divide amongst curative versus preventative care. And I think if we're speaking mental health, we're always wanting to be focused around how can we prevent mental health issues from happening, and then rather than focusing on curative the whole time. Other inequities, as I've spoken, I think there's a lot of human resource constraints that we find certainly within the rural spaces, fragmentation of the services that happens as well, poor coordination, even between public and private institutions and the non-governmental organizations, and then obviously our traditional services. And just the levels of care, not speaking to one another continuously, is causing a massive divide and massive problems in terms of even how patients are meant to be receiving care within a South African setting. I think when we speak around the psychiatrist in the South African setting, so to become a psychiatrist, you have to train, and it's post your undergraduate years, which are 6 years, and then internship, which is 2 years, and then doing a community service year where you work in a rural environment, which is 1 year. You then have to go back and specialize in psychiatry, and thus do a further 4 to 5 years of specialization before you become a psychiatrist. So if we look at that span of time as well, it's taking about close to 17 years before someone actually becomes a psychiatrist within a South African setting, just because of how our health system training structures are put in place. And according to the South African Society of Psychiatrists, we have over about 350 practicing psychiatrists in South Africa, and 60% of them are in the private space. What I haven't included there is that now we've got massive individuals leaving our country and going to, other countries like Canada, Australia, New Zealand, Ireland, UK, you name it, because they're seeking better health systems for them to be able to work in, but also seeking better lifestyles for them to be able to live in. So we've got this brain drain that is happening even within a South African setting. And we've got about 0.39 of our psychiatrists per 100,000 population, making us one of 45% of countries with less than one psychiatrist per 100 population in 2014. I haven't seen the latest stats, but in 2014, that's our numbers. And so there's a massive need for creating a different cadre of health professionals who have skills to be able to deal with psychiatric issues and psychiatric conditions within a South African space. And certainly this would ensure that we're actually providing adequate services to our communities who are mainly in need of healthcare services. So when you're practicing within a primary healthcare setting in South Africa, and especially a rural primary healthcare setting in South Africa, much of what you see is what presents to the casualty setting. And it's mainly these aggressive patients or patients who have suicidal ideations or suicidal intent, patients who are exposed to violence or trauma as well, come with psychiatric conditions. We see quite a lot of anxiety and stress and mood disorders also coming into South African setting. And again, complications from substance abuse. Now, South Africa has a very bad history with substance abuse, and certainly alcohol as one of the big ones. And this is historical again. So years ago, during the apartheid era, how the apartheid government sometimes would control majority of our individuals in a South African setting, which is Black Africans, would be by ensuring that there is alcohol within their settings. And because, they would not be able to go to work, they wouldn't be able to enjoy any other places of our country, they would literally sit and drink and try and drown their sorrows many a times. And unfortunately, that historically has somewhat continued in many of our communities, and it's causing multiple health-related issues and mental health-related issues within a South African setting. Now, community involvement is, again, something we need to be thinking about. And unfortunately, very minimal involvement from communities and families happens. There's very minimal support groups within communities, and specifically rural communities, that support individuals that have mental health. There's this massive divide again between rural and urban communities, with the urban having more resources available to them in terms of non-governmental organizations which support mental health issues. We've got psychiatric hospitals. I just even think within a Durban setting, we've got about 3 psychiatric hospitals in terms of private, and we've got 2 in terms of government. And so, even that divide, and we've got a much larger rural community within a KwaZulu-Natal, where Durban is situated, but have very minimal services that are available. So there's poorly structured programs within community level. These obviously don't assist individuals in terms of the transition from being in hospital to actually going into communities and how they should handle themselves and how communities should handle individuals who have mental health issues. And so rather the focus is rather on health workers advising families on how to care for their family members on their return home, rather than us engaging with the communities and training them up on how these individuals can be functional within these particular spaces. And so there's a massive, massive divide. And I think there's even more complexities in the social cultural factors that are actually involved when we speak about mental health issues. Modern Western medicine is more acceptable nowadays in South African rural communities, but traditional belief systems still dominate. And individuals come in, and over 80% of individuals who would come and consult a medical doctor in a rural community or rural setting have started at a traditional healer. And so we need to be aware of that. We need to engage with that, and we need to have an understanding of it. We need to start to have a cultural understanding of how individuals see illness, and how in their culture, what this illness actually means. And so we need to be able to be working with the traditional healers, understand how they make their assessments and treatment plans of individuals whom they regard with having mental illness, basically. South Africa has about 11 official languages, but still, with over 25 years of democracy, access to mental health care services is still compromised by very few psychiatrists, speaking indigenous languages even, within these particular settings. And so we need to be looking at all of those things. Yeah. And so really, over the years, these cultural factors, cultural factors included in diagnosis and treatment of traditional-oriented Black psychiatric patients is being seen to be very important. We need to be thinking about whether there's a cultural explanation even for how hallucinations are happening. And we should be training our medical doctors who are within an urban setting to be able to be thinking about that when they get into the rural spaces and how they care for individuals within the rural spaces. So it's really critical that we start to consider collaborative models, even as how those doctoral papers were also mentioning. How do we start to think about how traditional healers can be working together with the medicine, Western medicine side of individuals? And how can this care then be provided appropriately, collaboratively, basically? So in conclusion, just reminding us of our case, Mr. Nkabinde, who's a 33-year-old male who came in clearly psychotic, managed at the district hospital for 72-hour observation, then referred to a psychiatric institution thereafter. He is once again admitted in the medical ward in order to rule out that general medical condition, as we said, is observed for 72 hours as per the health regulations. On completion of that 72 hours, is transferred to the psychiatric hospital, which was 3 hours away from the district hospital. He stays there for 2 months as an inpatient. 2 months later, he returns to us at the district level hospital with medication to be taken as an outpatient. And what do? We discharge him home with the review date for a month's time. There is no other plan for him. So what hope does he have going into the community, living alone in a one-room shack, and the community already even isolating him because they see that mental health illness as something that is against the community, going to affect the community, he's a danger to society? Who monitors him in terms of medication that he's taking? Who's responsible for him in terms of ensuring that he takes his medication and ensuring that he gets food, ensuring that he's involved in other crafts and so on, and really being a part of that society? And these are real questions that we're still grappling with within a South African setting, and they give a real good picture of mental health within a South African setting. Thank you very much. That's the end of my presentation. And yeah, I will now just take any questions that anyone might have.
Great. Thank you so much for your talk. It was truly incredible. I'll start off with the first question. I really like the way you talked about integrating culturally competent care and how it's very important to understand the role and the importance of traditional healing in mental health care. And I was just wondering if there are any models or how you see the integration of traditional healing into the two main, like public and private, more, I guess you could say, Western healthcare settings.
Yeah, so there is pockets of that is happening within a South African setting in certain communities, but it one is either triggered by the particular provinces where they decide, listen, we understand that there is a lot of traditional medicine that is going on, and certainly I think for the province that I'm within, which is KZN, we are seeing that coming more and more, where now all of a sudden the traditional healers and faith-based healers are individuals who are also involved in the board within the healthcare system, and that particular hospital, for instance. So they get involved in decisions that are made with regards to how healthcare is provided, but it also then gives a voice to individuals who have committees. So the traditional healers themselves have got certain committees within communities that are able to now speak into health services. The biggest thing that we've been fighting, though, is that there is a lot of, I'll call it fly-by-night traditional healers, individuals who, they just want to do it. And they're not necessarily professional in terms of how they even do it. They speak a lot of things that aren't even true for certain individuals. And I'll give you a little bit of an example here using myself, so I obviously grew up, I'm a Zulu African male, and grew up in a sort of semi-rural environment. And when I was growing up, I had what now I interpret as IBS, irritable bowel syndrome. But I would have certain flares of this irritable bowel syndrome. And my first episode of having this irritable bowel syndrome, I was visiting an aunt who stayed within a rural community. And when I came back to my household, because what we then practiced was traditional medicine before going to see the doctors in a hospital, my mom took me to a traditional healer. And this particular traditional healer looked at me and he said, "Oh no, what is happening to you is that you've been bewitched by your cousins." Because where were you? Oh, you were visiting. Yeah, they gave you something in your food, and that is basically bewitched you. They're jealous, basically. And that brought quite a bit of rift within the family, where there's this traditional understanding somewhat of what has happened. Meanwhile, later on, a number of years later, I found out, no, you've got IBS, and certain foods are affecting you, and you name it. And so that then became a diagnosis. But it just gives an example of individuals, again, who are within communities who are practicing traditional medicine, who seemingly are doing the wrong thing, and they're giving wrong advice, wrong diagnoses to individual, and causing quite a bit of problems within the community. So we're trying to say, how can we streamline that so that when we're working as the health system, we're working with individuals who are professionals and trained in traditional medicine. And then we can be able to actually engage with them on that. Listen, the person who comes in and has these particular symptoms, please, this is TB. Refer them to us as much as you're going to do something else, but this is pulmonary tuberculosis, or a person who comes in and their left side is not functioning. You may interpret it as someone put muti outside and they walked over the muti and now their side is, non-functional. We see this as a cerebrovascular accident. Please refer them to us so that we can also manage them for what is happening. So we're trying really, and there are pockets of that happening. But also at the same time, we in the medical school are starting to integrate cultural understandings of care, cultural humility. So we're training our medical students on understanding how to make cultural diagnoses and know that individuals who come to them will not just accept taking that pill, but they will have a cultural understanding of their illness. So there's articles, for instance, that we use. One of them is Benson and Kleiman, I think it is, that looks at a cultural understanding model of care. And we use that to teach our students. We use that for them to take a history even from individuals, who are coming in on, okay, so what is your cultural understanding of this illness? What do you call this illness? What does it do in your body? And that gives the patient's perspective from a cultural perspective of what is happening to them. And I think for a lot of our students, even who come from many of these cultures, because they have been training in Western medicine, they automatically have blinkers to anything else. And so we're trying to just expand that and open that up to say, yes, we want you to still train in Western medicine. We want you to practice Western medicine. We don't want you to practice traditional medicine, but we need you to understand how to engage with individuals who are coming from those spheres. So yeah, so there is a lot of models that we're trying to put in place, definitely, to see how we can actually help in training up our health workers and bridging that gap, between traditional medicine and Western medicine in South African setting. Yeah.
Great. Thank you so much for sharing.
Pleasure.
Does anybody else have any questions? Amara?
Amara, yeah.
Yes, hi. Thank you so much for your talk. It was wonderful. I'm concerned about that 1% of the budget being spent on mental health. What would it take to have that percentage increase in South Africa and then broadly speaking across the continent? And what steps can we do now to get that up?
Yeah. So I think it's just more mental health awareness, and mental health awareness, not just from us as healthcare workers, but from the actual communities who vote for our politicians. You know, we always look, and certainly in South African setting, and say that our healthcare system in a South African setting is run by politicians. They make decisions on budgets. They make decisions on where money is spent or not spent. And they may call us as clinicians to come into certain meetings, and, you know, we can present data on what we're seeing and where things need to be, or where money needs to be spent. But ultimately, they still make the ultimate decision. And I think for as long as there is this continuous stigma around mental health, and also this neglect of mental health for individuals, even for the politicians themselves, you know, they don't see mental health as something that is important. Even amongst themselves. If we can change that picture, and I think change that picture from the voice of the communities, you know, having advocacy coming from the communities, and then that advocacy speaking with us within the health systems, something can happen. And it's difficult because, one, you need the human resources to be able to influence the communities to start to really engage in that conversation. I think, again, you know, the Life Esidimeni case that I spoke about for South Africa should have been a massive wake-up call. We should have literally, in all of our provinces, should have said, this is an injustice that we are seeing everywhere, but it has been highlighted because it's within an urban setting. And it's an unfortunate case that has now gone to the courts, but this is happening everywhere else. How many of our mental health patients are dying and we know nothing about it? You know, how many are in jails, for instance, and they're wrongfully accused because they've got a mental health illness and they do something wrong, but they end up in a jail. So all of that, I think, needs to be rising from our communities for us to really start to think about how can we change the spend of money that is happening. But also, I think there is this thing again of we neglect mental health services. So if we look at the district health structures within a South African setting, and even how with the decisions with the boards, the mental health care boards, and you name it, of saying, okay, well, district level hospitals are now going to admit psychiatric patients, but we don't have a psychiatric ward in a district level hospital. These patients are admitted with medical patients. So a patient who's got pneumonia sleeps next to a patient who's got psychosis. And you have to sedate the patient who's got psychosis because you don't want them to wake up in the evening and mistake this person who's got pneumonia as something else, you know, and harm them, for instance. So we've got those issues that are happening. Yes, the mental health board and the review board, that is, we're obviously trying to make sure that we're not institutionalizing individuals inappropriately. Because again, that was very easy to do. You come in, you're psychotic, let's send you to a mental health institution, lock you up for 6 months, and that's the end of you, you know? But rather we need to assess individuals appropriately. So the structures need to change, but the structures for them to be able to change and for us to have proper mental health regulations within these hospitals and infrastructure, that budget needs to go up. But we need the voice of the communities. And that's constantly something that we are trying to engage with. And by getting us to be advocates, you know, for these communities and saying to them, guys, you need to speak up. This family that is suffering from mental illness are not the only ones in this community. How can you support them? But then how can you get your leaders and your government to support them as well? You know, and that is very, very critical.
Thank you so much. I can imagine getting the advocacy from the families to be very difficult because of the stigma associated with it. What strategies have you guys used to get the advocacy that you're seeking?
So there are many advocacy organizations that are there, rural health advocacy groups and so on, that have certainly tried. It is not in the forefront again, you know, and I think that is the big concern. It really is not in the forefront, and, you know, within our time. I think we're dealing with so much that mental health care becomes forgotten. And that is unfortunate. So we're not doing what we should be doing, to answer you, I think, more directly. Certainly more can be done. But it is around the awareness groups that are coming through. Remember, for a South African setting as well, yes, we are dealing with other multiple comorbidities that are affecting us. HIV is a massive one. We've done very well in terms of our HIV programs, getting individuals to be on medication and so on. And so it is critical that, yes, we focus on those. And so again, mental health becomes last on the list. We think about TB and we think, no, we need to really focus on TB and managing patients with tuberculosis appropriately and stopping tuberculosis within our communities. We think about malnutrition. And so all the money and the resources and the voices and advocacy goes towards those. And we do forget about the mental health patient, because they can't speak for themselves. Now, we've had a number of our own colleagues who have suffered with mental illness, starting awareness groups, social media being used as an awareness group, them speaking about themselves and how they integrated within the healthcare system and how they felt treated within the healthcare system, the same healthcare system that they work in. And I think that has helped, certainly, in trying to get this awareness going. But it's not enough still, because it's just one lone voice. If government, again, came through and said, we are willing to spend this much money on mental health, and this is something we want to really curb as South Africa, then things would start to happen, because we need those resources, for it to really happen. So it is lacking. Yeah, it is lacking.
Thank you so much. You answered so many wonderful questions, and I know there's one from Joy in the chat. I just would love to hear your thoughts, maybe after Joy's question, about how I think South Africa did a really great job of talking about apartheid after the fact and just having a whole national conversation about that. I'm wondering if that same model can then be applied to the mental health model, but definitely Joy's question first, and then we can go from there. Thank you so much.
Sure. So just reading Joy's question. One of the things I've noticed this year in my rotation in regards to mental health is that the basic needs of patients who have mental health disorders like food and shelter have often not been met. In your experience as a physician with strong roots in community building, how does that work to address these needs in the context of treating mental health too? Yeah, so thank you, Joy, for that question. Look, it's a massive problem. And I think even the case that I've used, as much as it is not a real case, but trust me, there are many cases that are like that. Individuals who live alone in one-room shack because the family has just said, we're not going to be willing to deal with them, or they lock them up in a particular shack and open, the door in the morning. So we see a lot of that. Now, what happened then in a South African and rural setting was what we call war rooms. And these war rooms are structures where they get different government organizations. So from social work to infrastructure to, the municipality, and then obviously from health, coming together and having a look at certain individual cases that are brought in by community members to say, so how do we actually help to solve these individual cases? So how do we provide food, for instance, for this person who's suffering from mental health? How do we think around shelter for this individual? But they're going on an individual case and basis, which is not enough, because in a population of 100,000 people, you treat one person who lives in a shack who's got a mental illness, you haven't solved the problem. When you've probably got about 5,000 individuals who suffer from mental health within that particular community. So the structure of that is really not working well. Now there are, what we call out-based teams or ward out-based teams, which actually go out into communities to try to help to treat health ailments within a South African setting. And often these ward-based outreach teams have a nurse, have a community caregiver from that particular ward or environment, who then goes out and they help to try and solve certain issues. Now they will call in some services from social workers sometimes, they'll call in the occupational therapist if they're going to see a mental health care user, for instance, within a community. and they try even, to get the dietitian to see then how do we work around what is happening with that particular individual. But again, it's far and few in between. And so it is a massive issue, Joy. And I think it's something that certainly for us as a third world country and dealing with, 70% of poor people living within a rural environment, it is hard, I think, for even the government to try and fill the gap in sorting out the food and the shelter. So what they've done is they've provided grants, disability grants, which the disability grants really look for disability. And sometimes psychiatric illness is not seen as a disability, in that space and in that time. And so there might be brief grants that are given to individuals, but we forget that they go through cycles. If they've got a mood disorder, they go through cycles. It's the ups, it's the downs. If they got schizophrenia, for instance, there are cycles as well, where they start to have, if they're not controlled, those acute episodes that we're not dealing with. And that further then destabilizes them and destabilizes even the income that they're getting, and then perpetuates that food and shelter lack that is happening in our environments. So it is an ongoing problem. And I think for us, certainly, it is very hard to deal with for individuals who are not institutionalized and are getting that shelter for the time that they're within a psychiatric institution and getting the food in that time. When they're discharged, many a times it becomes okay, you are fine now. Medication is sorting you out. Hopefully you're going to go and find work, or you're going to go and sort yourself out, in whatever environment you're going to. So it is problematic. I think in terms of the second question, maybe if it can just be repeated, trying to see who had raised it.
Are you talking about the one about apartheid?
Yes. If please.
That was me, Amara.
Oh, yes, Amara. Sorry, I can't see it on the screen. So, yes. So if you can just repeat that question, please.
Yeah, definitely. So it was around the thoughts of how to utilize the tenets of what South Africa did post-apartheid in terms of conversation in the entire country to the same effect for mental health. I think you guys did a really good job talking about it, and something that if I ask anybody from South Africa, they can speak to it, right? And so it seems like there's a system in place already to disseminate information to the masses in a way where everybody can be engaged. So I'm thinking that it could potentially be helpful in the mental health aspect as well.
Yeah. I think that's a good, good saying, Amari, and something that, yes, we can possibly look at. My only concern is that, again, mental health is not being seen on a wide scale as something that is a pandemic in a South African setting, even though it probably is. It's not being seen as very important. And so because it doesn't affect me, I don't have to speak about it. I don't have to think about it. I don't have to raise awareness around it. And I think that becomes the real problem. I think apartheid, whether you were on the benefiting side or the negative side of apartheid, it affected you somehow, and so it was easier to then speak about it. Certainly with democracy coming through and the change, even if you were on the positive side of benefiting, all of a sudden, because you felt like things were going to be taken away from you, you felt you needed to speak. So you would engage in conversations. I think with mental health, because again, it's still very stigmatized and no one wants to speak about it, and it's not being seen as something that everyone suffers from, even though we all suffer from something related to mental health at some point of our lives, or some point of the year. It's just not seen as very important. And so it's not going to be given the platform, that apartheid was given. And so, yeah, so that becomes a real big problem. I think what needs to be heightened, and hopefully will be heightened at some point, is again those awareness campaigns, and the things like National Mental Health Day, where the journalists are coming on board and say, guys, let's speak about mental health, where the politicians are saying, yes, we're raising awareness around mental health, where the presidency is also raising it as a concern, then it's easier for everyone to start to say, oh, we can speak about this openly, but now how do we help to solve it, you know? But really the initial parts is us speaking about it first and foremost, and then get to how we can solve it. So yeah, so hopefully we would get to those points at some point, but you know, again, as I say, we're just dealing with so much else as a country that mental health is just left in the background, you know, and it's deemed as not important, unfortunately.
Right, you make a very good point. Thank you so much.
Pleasure.
I just want to say, I think our time is just about up, Dr. Nkabinde, but thank you so much for taking the time to present to us today and for sharing your knowledge and expertise during this presentation. So thank you again.
Absolute pleasure, and thank you for having me. Yeah, I've really enjoyed speaking about this, and it brings awareness to me as well to start to speak more and more around mental health, you know, certainly in our spaces. So thank you very much.
Great, thanks so much. Great to see you.
Yeah, good to see you as well, and hopefully see you in a couple of months, guys.
Absolutely.
Yeah, looking
Appreciate it.
forward to
Thank
it.
you for this wonderful presentation. One of the best ones we've had for the entire course, from my perspective.
Absolute
So
pleasure.
you just have really a lot of insight into the complexities of the issue, which is hard to do in this short period of time, and you do it beautifully. So thank you
Thank
so
you.
much for that. And we can't wait to
Thank you
meet you
very
in
much.
person here. We'll bring
Yes,
some of these
yes.
people together to get them in a room with you.
Oh, that would be lovely. That would be lovely. Yeah,
And you'll
would
see
love to meet.
faces instead of black screens, hopefully.
True. True. No, thank you very much, Tracy. Yeah, and yeah, I certainly enjoy doing this. And so anytime, and any topic that you feel may be beneficial, you know, to you guys in your environment, and I think giving our perspective from an African environment, certainly, yeah, would love to give more. So yeah, thank you very much for having me.
Thank you
Yeah.
so much. So enjoy the rest of your day, and we'll be in touch soon.
Thank you. You too.
Bye,
Bye.
Thandaza.
Bye-bye.
Thank
Bye-bye.
you.
Bye, everyone.